Good morning.
Hi, Dr. Alsaati. Welcome back.
Sorry, my computer just completely decided to restart.
No worries. All
Can
right, let's
you
go.
make me co-host?
Yeah, sure. Let's make you co-host. All right.
Okay. All right. Okay. So we were at the achalasia case.
Mhm.
All right. So let me just brief you about achalasia. Achalasia is not a diagnosis that we can do on microscope. Okay. It is purely, I don't know what's going on with my computer. It's purely a diagnosis that requires multiple imaging and clinical manifestations. They have to correlate with imaging. The patient will come and tell you that he has a lot of discomfort. Lots of times, if the patient is an older patient, they will go ahead and do they have to exclude cardiac problems. Another name for achalasia is basically cardiospasm. The patient will feel like they will tell you that my heart is, feel like my heart is stuck. I have like, it's very painful. But in terms of pathology, you have to know that achalasia is a problem with the muscle. It has nothing to do with the epithelium. I'll tell you now what we need to see in the epithelium. But in terms of the muscle, it's that circular in the inner part of the muscle, the inside one, the one that's usually circular, not longitudinal, that's the one is hypertrophied. And this is a very good example of it. You see how thick this muscle is from here to here
Mhm.
as compared to this outer muscular layer.
Right.
And you will basically have the myenteric plexus. I mean, we should have some here. It's not like completely lost, but usually there is no myenteric plexus. Sometimes it will be going to be the nervous component is very, very, very decreased, and
Mhm.
so it will fail to relax. What does that mean to our surface epithelium? If we know from the patient's history that the patient has achalasia, I will look for three things. Reflex change, which the patient has here. He has it in multiple, he actually has the whole shenanigan. Increased lymphocytes everywhere.
Mhm.
Papillomatosis, 1, 2, 3, 4. It's like papillomatosis is just that the squamous papillae will almost reach the top, okay?
Mhm.
And spongiosis, basal cell hyperplasia, the whole thing. And they have a lot of increased lymphocytes, as you can
Mhm.
see. When we say the word like lymphocytic esophagitis, which if I mean, of course, I don't have the muscle layer in my biopsy when I get the biopsies. But if I got a biopsy like this and I have a lot of lymphocytes in the esophagitis, I call it lymphocytic pattern
Mhm.
esophagitis. And I will say in my comment that this is a descriptive rather than an entity, just explaining that this is an increased amount of lymphocytes. The increased amount of lymphocytes can, or we call it uh, um, lichenoid pattern of inflammation, and
Mhm.
it can occur in patients with achalasia. It can occur in patients with severe GERD, and it can occur with patients with lichen planus. And so
Mhm.
we'll just have the doctor to like think more about other entities rather than just blame it on the reflex. Let
Okay.
me see the surface here. So those lymphocytes pretty much reach the surface. This another thing that I will do here is definitely a fungal stains. because with achalasia, there will be a lot of spasm, and it's a good area, a good environment for fungus to stick. It's not relaxing, and the food will be stuck. Other thing I want you to also not to forget is also dysplasia. Dysplasia in the esophagus, I rarely call low-grade dysplasia. However, high-grade dysplasia is sometimes you can see, but for me, this is all reactive in nature, nothing to worry about. But yeah, that's a nice achalasia case. Let's move on. Sloughing esophagitis. Good. I hope that we're going to get nice pictures here about it, because that entity, as I said, is not uncommon. So let's master it on low power, then we will go high power. And I promise you, when you get esophagus and you see this, you'll be able to make the diagnosis really quick, okay? So on low power, okay, first of all, the paperwork that comes with the case, you will look if the patient has dysphagia, pain. What did the clinician see? He will tell you that I either see white plaques, or I either see friability of the esophagus, red erythema. So there are some hints that telling you that this esophagus is not completely normal. Now I go to my low power, and I see right from the start that this is a basal cell of the esophagus. Then that's the mature squamous epithelium. And then this one from here to here is a complete, nice, connected piece. And I can see the difference in color between the surface and the base. Now, this one, I'm very interested to go high power. Over here, I'm also interested to look at this piece here and this piece here, okay? I mean, of course, I'll look at everything, but on low power, these attract my attention because I think these are the pieces that I will make my diagnosis upon. Now, let's see. Over here, I went high power. Base looks okay, maturing nicely. And then suddenly the color flips from purple to pink. And it's a very nice line from here all the way to here. And then I see the surface completely dead. There is not a single nuclei in the surface. Okay, this is classic. You can, just while your eyes are closed, call this sloughing esophagitis and move on. You don't have to describe anything in your comment. You don't have to do anything. You'll say fragments of esophageal mucosa with friable surface, most consistent with sloughing esophagitis. If the doctor calls this normal, completely normal, you will be descriptive and say, no fungal organisms seen. Correlation with clinical history is recommended to rule out esophagitis dissecans or sloughing esophagitis. So the pieces that I saw on low power were these. I was looking for anucleated squames, but this is not true. These are all nucleated. And
so what's the cause of a sloughing esophagitis? I mean, apart from dysphagia, what type of symptoms they can have?
They can have, it's pretty much pain, dysphagia, GERD, reflux changes. Patients might have some skin problems to start with. So it could be a part of a systemic skin disease, not only part of esophageal. It could also come from chemicals, erosive esophagitis. So multiple reasons can cause it, but
so will there always be this kind of two-zone pattern like blue and pink?
This is the classic. This is the most classic. This is for you to make the diagnosis. Otherwise, if you don't see that, and you see only anucleated squam as the surface with no change in this, you might suggest it and you will say sloughing pattern of inflammation or reaction in the esophagus. You can't be pretty much sure of it. But Yes, here, this is a nice one. See that area here?
Yeah.
You will get like pockets and pockets on your slide of just anucleated squames like that. By far, it's my favorite esophageal entity to make the diagnosis for. I don't know. All right, now the next one is this one. Let's see, this is another example of sloughing esophagitis. It's good to have two back to back. And this one here, you see the separation? Because this is the zone where it starts to separate. Okay.
So the one that sloughs from the top is not something that you should think of. Like that can happen in Canada too, but the one that sloughs from a little bit in between.
In between, yes, 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 yes. It has to be, you have to have a nice
Top.
area on top of the
Yeah.
sloughed area to
Yeah.
call it.
Got you.
Even this one, if you want, this one doesn't have a lot of enucleated squames at the top.
Yeah. Yeah. But then it has a zone of separation kind of thing.
Correct, correct, correct. Let's screen everything. Oh, beautiful here. See how? And honestly, this all is reactive, but if you have a little bite of these only, you want to make sure that you're not missing a dysplastic process. That's very beautiful. Two examples back to back. Okay, let's move on. Intestinal type adenoma arising in autoimmune gastritis. We spoke about autoimmune gastritis in a separate lecture, in a separate, on our previous series. This here is a classic. You see the atrophic mucosa, you see Paneth cell metaplasia, you see extensive intestinal metaplasia, chronic inflammation, and we do a Gastrin stain. This is going to be completely negative. We do a chromogranin stain or a synaptophysin, and you will see the ECL cell hyperplasia, which is basically few glands here and here. Okay, now they mentioned that there is intestinal type, gastric type adenoma. Okay, this one, if you don't know, it's a stomach. What would you call it?
Tubular adenoma.
Exactly, exactly. And this is the exact definition of the intestinal type adenoma. And it's just a gastric adenoma. Here you can see probably changes consistent with a funding gland polyp or funding gland change with a surface low-grade dysplasia. Now, if the doctor said I have nodularity versus a polyp versus a mass, this will change my terminology. I will end up calling this adenoma versus low-grade dysplasia arising in AMAG background versus funding gland polyp with surface low-grade dysplasia. But for me, this one, it looks like one big polyp trisected, 1, 2, 3. And these are the intact gastric pieces. Okay. Yeah. Very important to make sure you don't have high grade. So you go closely and you kind of screen your epithelium. If you have suspicion, do not hesitate of going ahead and doing a level. The most dangerous part of GI pathology is you want to finish your cases. And sometimes you just use your judgment and said, you know what, I'm just not going to do a level this time. It's just, I know it's going to turn out to be negative. No, please get into the habit to slow down and get your levels and rule out, give each case, behind each case is a human. Give each case a lot of attention to make sure you're not missing more serious stuff. Okay, now moving on. Stomach adenocarcinoma poorly differentiated. Let's see. Again, another resection. Where are we? This is gastric. All right.
Yeah, that's nice.
Yeah, so this one, yes, adenocarcinoma poorly differentiated. This one I would also mention, call this poorly differentiated adenocarcinoma, comma, diffuse type with signet cell morphology. Okay, and this is a beautiful signet cell here. Why is it important to mention signet cell morphology? For multiple reasons. The one major reason that I like to mention it is when they metastasize with signet cells like that. And it's very nice if the patient has correlation that the original tumor has signet rings. This way the doctor will not, like, think all over the place. Let's do renal markers, let's do lung markers, let's do breast markers. No, they know that the original has signet cell morphology. Okay.
Right.
I wish all the tumors are that prominent, but that's not the case at all in signet ring cells. Okay. Intestinal type, no, okay. Oh, that's another one. So I'm gonna ignore it. Correct, Kansha? Should we? Okay. All right. So this is just another image on the same patient.
Yeah.
More of it. See, it's okay. Let me one small piece of advice. Again, your low power is your most powerful tool. Okay. So on low power, you see expansion here and destruction of the pits. I see some here. So these are the foci that you need to make sure you're not missing tumor. And for this one, I'll definitely do a keratin on it if it was on a biopsy, because I'm not sure if these are tumor cells, which I think they are. These all are tumor cells. See them? Yes, very subtle. I mean, not the whole thing has tumor. You probably only have 10 here. There's this beautiful one over here.
Yeah.
Okay, so not the easiest diagnosis to make. Okay. H. pylori gastritis. I think this is an easy one to look at, but very, very, very important because you basically will have 4 or 5 a day. Your low power diagnosis will say that I have a band of lymphocytes. You see how my band is more superficial towards the surface? You will have, of course, deep pockets of lymphocytes, but just by looking at this, if my H. pylori is negative, I doubt myself again and again and again, and I squeeze the H. pylori out of my immunostain because you will find it. Okay, so don't rush on your H. pylori stains. So this is the one thing you need to look for is intestinal metaplasia. This is, of course, body type mucosa that you will look for intestinal metaplasia. And I don't see any. Let's look at the immunostain. And that's exactly what I'm saying. Squeeze yourself to find it. They are there. They are. Okay. It's not loaded. I'm pretty sure you've seen H. pylori stains that are everywhere. But these are here, the H. pylori organisms, and they are deep in the pits as expected. Okay. And okay, normal stomach. Oh, that is interesting. Okay, that's a nice case because they call it normal stomach, okay? So which is very cool because you have nice oxyntic mucosa with surface epithelium, very normal. And pretty much nothing. Okay, here, I know my colleague actually taught me something. She does not like lymphocytes on their own to be sitting like that without, she actually does look for H. pylori every time she finds a single small lymphoid aggregate. It's chronic H. pylori infection or an active one can cause deep lymphoid aggregates, even if the surface is completely intact, okay? And here I don't even have activity. All right, but of course, oh, CGA. I think that's all right.
Is it chromogranin or something?
Chromogranin. What are they trying to do? Oh, okay, I see, got it. So they're not trying to show you that what's the normal pattern of oh, like I really don't know what they're trying to do here, but these are all interior chromaffin cells of a normal stomach. At first, I thought they were trying to make you look for H. pylori in normal stomach because it is also very common. So keep in mind that even H. pylori can be present when you have very, very normal stomach. But they're here just showing you how the anterior chromaffin cell in a body should look like and the difference between it and AMAG, where you have to have nodular and linear ECL cell hyperplasia. Okay. Cool. Knowing histology is very important.
Alsaati, can you please go over the gastrin stains and like in autoimmune gastritis, how it will be helpful?
Yes,
please?
of course, of course.
Thank you.
So this is basically a case of autoimmune gastritis.
Dr. Alsaati, can you explain to her what happens with gastrin, like in autoimmune? Does it like disappear or?
Yes, yeah. I'm about to say that, Akanksha. I will have both these cases together, the normal and the atrophic and the
nice.
autoimmune. So these three cases are almost connected. And I see a beautiful autoimmune gastritis. He's with a lot of images, and I would prefer to explain it with
maybe
with
they have a Gastrin Strain too. That's
exactly. So I'm gonna go directly to here and see. So here, I will open everything and see what they have. This is a gastrin. Just want to know that CGA, it stands for what stain? Is it chromogranin?
I think it is chromogranin A.
Okay. I'm just opening everything to make sure that we have a full view of everything before we proceed. So this has multiple H&Es. Okay, let me make sure. Okay, we
so they are doing different examples or something. That's why they.
These are So 1, 2, and 3. This is a good case. Okay, so I don't know who was asking about the Gastrin Strain. So before we move on with our H&E, for patients with suspected AMAG, we will get an antral biopsy and we will get a body biopsy. Okay, the antrum doesn't have oxyntic mucosa, and it is easy for us to call it antral if the doctor is calling it antral, and we'll call antral type mucosa with reactive changes, blah, blah, blah. However, the biopsy from the body will be quote unquote antralized. That means the oxyntic mucosa that's supposed to be within the antrum is lost because of the antibodies against the intrinsic factor that will cause atrophy of these oxyntic glands and then loss of them. So we call it antralized type mucosa or atrophic body type mucosa. Okay, so how do I know? If I don't have oxyntic glands, there is no way for me to know that this is truly an atrophic body, right? So what I do is I use some stains to help me with that. Number one stain is gastrin. Number one and only actually is gastrin. The gastrin is positive in the antrum, truly positive in the antrum, and dead negative in the body. Okay, so I will say in my comment that Gastrin stain supports a body origin of the biopsy. Okay, that's what you do. You will call it that way, and then that's all what you need to do. No, but because look, I don't have any gastrin secreting glands here. It's all dead. All right.
I wish they had given a normal antral mucosa with gastrin too.
They did. Okay, let's look.
No, I wish they had given.
Oh, yeah. I mean, even you go ahead and stain any antrum at work and see how it looks for you to picture
Understand.
that.
Yeah.
Okay, and then now that I have a dead gastrin, I know that this is a body. That's when I do my chromogranin, because if I did a chromogranin on an antrum, you will see ECL cell hyperplasia. You will see a lot of ECL cells, and it's not significant for you. You have to do it on a body because that's where your enterochromaffin cell will be pathologically hypertrophied, okay? And there it is. This is my chromogranin. And you have to have, hold on, let me see. Okay, so you have to have nodular. So all of these are positive. There's like almost a nodule of enterochromaffin cells. Another one here. And I don't see a linear one here. Let me see if there is a linear. I'll tell you what a linear ECL cell hyperplasia means. Okay, you see these glands? So here, 1, 2, 3. If you have 2 more next to each other, if you have 5 cells here, then this is linear ECL cell hyperplasia. I don't see it here. I only see nodular hyperplasia. Let's see here. Okay, there you go. 1, 2, 3, 4, 5, 6, 7, 8. So this is linear. And then when they become a small nodule like this one here, it will become nodular ECL cell hyperplasia, this one here. Okay. And this one here, my chromogranin, is not as beautiful as usual. Usually it is much more, you know, I do see it in a much more prominent way. So let me look again on the H&E, because that's the key for a lot of things. So why am I ordering a gastrin here? Because the doctor labeled it as body, okay? And I don't have any oxyntic type mucosa. I have chronic inflammation. I have Paneth cell metaplasia. Let me show you the Paneth cells. These pink granular cells are not normal in the stomach, okay? These are metaplastic. So I have Paneth cell metaplasia, I have intestinal metaplasia, I have chronic inflammation, and I have loss of oxyntic mucosa. I don't have any oxyntics. Nice, simple. Now you have an overview of about what needs to be done. And then also another, oops, here is pancreatic metaplasia. See that? Again, so also what
Can
do
I
we
ask
need
you
to?
one more question in between?
Yeah.
Sorry. So you said it's antralized, right? So
Yes.
it should turn like, it should be looking like a gastric antral mucosa or intestinal metaplasia, or how?
Okay. So not a lot of people use the word antralized. Antralized is just telling me that I could not differentiate between an antrum and a body. Okay. One of my fellowship mentors used to use that. It actually justifies his Gastrin stain, because for him, when he uses antralized, is because I cannot tell that this is a body biopsy. That's why I want to do a Gastrin stain. but you don't have to call it antralized. I'm just doing it for to make it closer to your imagination. But pretty much it is antralized because it may look to you like an antrum. However, with IM and Paneth cell metaplasia, and so in your head you have to have a checklist. I say number 1, loss of accentic mucosa. Number 2, intestinal metaplasia. Number 3, Paneth cell metaplasia. Okay. Number 4, chronic inflammation. Number 5, loss of gastrin. Number 6, ECL cell hyperplasia showed by chromogranin or synaptophysin. Okay, you have a whole big picture of this in the body. Then you will call this chronic atrophic gastritis. Differential is H. pylori versus AMAG. And in both cases, every case you have to do an H. pylori stain, okay? Because H. pylori can look exactly the same thing, and it is more common, okay? I hope this answers the AMAG questions. I know, trust me, I did it through my fellowship, but once I was hit with the number of AMAGs during my my work, I digged so deep to be able just to be very systematic and make the diagnosis. It wasn't like very spontaneous to me as well.
No,
But
it's
once
very
you
helpful.
Huh?
It's very helpful. Thank you so much, Dr.
You're
Alsaati.
very welcome. And then once you get into the habit about what to look for and how to proceed, it becomes very easy for you to make the diagnosis. Okay, moving on. I think AMAG got sufficient attention from us. Okay. Goblet cell carcinoid. We did once before. I'm just gonna go really really quick on it, just to tell you how subtle it is. I think we did it on Path Presenter, I remember, or something. So where am I gonna look for my goblet cell carcinoids? Look at that. Okay, these are the tumor cells, and that's a quite aggregate here, but you can tell, right? You can see them, they're infiltrating everywhere, here and here and here. Okay, and then of course your chromogranin. It's a cytoplasmic stain, and it's highlighted everywhere. Such a nice case. Such a nice case here, but such a difficult case when it comes to a small biopsy of the appendiceal orifice. Okay, all right, moving on. Oh, we finished page 8. Let's go to page 7. CMV. All right, the dot sign. All right. Okay, so first of all, I want to make sure that we're looking at an esophagus. But yes, we are. It's such inflamed granulation tissue. It's a weird esophageal biopsy. Oh, here you go. There's a nice, it's a very old slide, just to let you know that it's not as common to see CMV in the esophagus. But definitely you have an esophagus with an ulceration, erosion, and granulation tissue. Let me tell you how I went to that diagnosis. So first of all, because I'm also blinded to these slides, I want to know that this is a resection versus a biopsy, and obviously we have strips of esophageal mucosa here, and then one globule of something and another globule of something. And probably this is fibrin. So we went there to the esophagus. I saw nice maturation. This is beautiful. Submucosa, basal layer, mature, superficial layer. I don't have basal cell hyperplasia. I don't have spongiosis. This is very beautiful, healthy portion of esophagus, okay? Every esophagus you want to see, you want it to look like that. This sloughing here is not sloughing esophagitis. This is the normal, okay? So, and it is nice maturing and you have nuclei all over the place. So this is a normal portion. Let's go here. More submucosa and epithelium. And now I have a big granulation tissue. See that? Lots of small vessels, granulation tissue, surface epithelium healed with an ulcer. All right. Let's see if we can, now we know that it's CMV. Let's see if we can see the CMV. I don't know if that should be one of them. If you got a positive CMV, how many of you go, oh, this is a positive CMV, this one. How many of you go back and look for it on H&E? Oh
Yeah,
my gosh, look at that. 1,
Yeah,
2,
nice.
3, 4, 5. Oh, this is a nice one. Oh my gosh, if I got that, I will use it as a control for our CMV. Now more, see how that?
Yeah.
Okay, let's look at the stain. Oh, no?
Oh.
Oh, okay.
Well, they didn't even do the stain, maybe.
Huh?
They didn't even do the stain, maybe. Huh?
Exactly. All right, so now we have, well, definitely I would do immunostains on this. I will do a herpes.
Yeah, everything. Yeah.
Yeah, I'll just do all my bug stains, but yeah, they call it CMV.
Juvenile polyp, small intestine.
Juvenile polyp in children, retention polyp in adults. Okay, same entity, but you're not gonna call a juvenile polyp in somebody who is 70. So pediatric cases, this is a straightforward juvenile. For adults, which I see very often, we just call it retention chain, you know, polypoid with retention changes or retention type polyp. And what it tells you is it's that hyperplastic change here. It's just the mucosa gets edematous around the cystically dilated glands, or and the surface has to be round. Look at that. Okay. All right. This is the difference between a hyperplastic polyp and a juvenile polyp / retention polyp. Your surface is the giveaway. It has to be nice, smooth surface. Okay. Otherwise, if you have the papillae coming up and down and the serrated changes, you're dealing with a hyperplastic polyp, or you're dealing with a serrated polyp. This one is cystically dilated because the epithelium, the lamina propria around it got swollen and inflamed and kind of started pulling the glands in many directions and changing its shape. Okay. The pathophysiology between polyps is incredibly different from one to the other, from a hyperplastic to a serrated to a juvenile to an inflammatory to each one has a reason for it to occur, and each one has a reason for its shape to be changed. One, the pathology is in the lamina propria, one, the pathology is in the muscle, one, the pathology is in the epithelium, and so forth. So you need to keep that in mind. Okay. Pancreatic Cenar and intestinal metaplasia. So I think we know what that looks like.
We can see a pancreatic acinar one more time.
Okay. Okay, and just to let you know, when I started working, a couple of cases, I used to call it in my description that there is pancreatic SNR cell metaplasia, and I received a lot of phone calls from the clinicians, so I stopped saying that. But yeah, so I'm like, okay, so what is this? This is cancer? Is it metastatic pancreas? Is it what? So what do I do? I'm like, no.
Yeah,
No?
it doesn't.
And especially at the GE junction. So it's not something that is fun to mention. And by the way, it's very common at the GE junction.
Mhm.
There you go. Lots of Panath cell. The one we saw with the AMAG was a much better example.
Mhm.
Okay, here it is.
Mm.
Small piece of a pancreas laying down inside of your stomach. Completely just for you. When you see it, you have to just make sure you're not dealing with AMAG. Okay. Liver, colon, ischemic colitis. Okay. Okay. More common that you imagine. On low power. Oh yeah, on low power. Remember, ladies, on low power, you have to make sure, are we dealing with chronic or acute? Here, I don't have a lot of, see here, my colon is completely normal. When on low power, it's a little bit darker. Here, I can see that there's some pink material in my colon, so I go higher power. And I see that my surface has tethering, and not tethering, is the crypts are almost dying. This is a very classic case of ischemic colitis. You will have the surface epithelium denoted, and almost your lamina propria is hyalinized with pink material. Lots of friends of mine, they actually do amyloid stain. If it is classic like this, I won't. However, sometimes it's very subtle and you have pink material all over the place here, and I would do an amyloid stain here. The rest of my pieces are normal. This is a nice ischemic area, okay? So ischemic pattern injury, okay? And you will see that, you will say that this can be seen in ischemic colitis and infection, okay? Bugs such as parasites can also cause that, because they can go into the vessels and occlude it. All right. CMV, another case of a duodenum on H&E only. Okay, let me just go to the dot. Oh my God.
They're training us to find CMV on H&E.
Yeah.
Nice. There was one nice over there.
You found it?
The big one.
Here on the same area?
Yeah. Isn't that the one, the big one?
I can't see anything. Oh, this one.
Yeah, it's jumping at
Oh
you.
my gosh. Oh my God. Oh, there's another one here.
Big ones over there. Yeah.
Oh my God, that's so cool. Yeah, now we're training our eyes for CMV. Xanthelasma. Okay. Also, this is something that we see very often. You will call, the doctor will tell you he took a polyp, or not a polyp, a yellow plaque. Okay. What would you do here? Definitely you want to, I mean, a lot of the times you don't need to do stains, but sometimes those nuclei are too pushed to the edge and you just want to put your mind to ease, and you will do a keratin and a CD68. Okay, these will be keratin negative and CD68 positive. And you'll call this consistent with the clinical impression of xanthelasma. Why don't I just call it xanthelasma? Because surprisingly, even if the doctor didn't see anything, you may see a lot of histiocytes like that and foamy histiocytes within the lamina propria, and the doctor doesn't call it anything. So not all the time that they will be seen clinically, but when they are seen clinically, they are more nodular like that. Okay, just keratin and a CD68 should do the trick. Okay. severe active chronic malignant perivascular picoma. All right, my soft tissue colleagues. Okay, here, let's see. Oh, the what do they call it? The staghorn vessels all over. Can you guys remind me of the stains? I have not done that in a long time.
I don't remember too.
Well, I don't remember too.
I think it's those HMB 45.
Yeah,
I think.
melanoma stains, I
Correct.
think.
Melanoma
Yeah.
stains
Yeah.
and
Mhm.
S100 and HMB.
S100, right?
Great. For me, it's going to be a lot of reading before making this diagnosis.
Yeah. We'll be having soft tissue expert here as well.
Okay, so hemangioma. No, that's esophagus. Am I in the right place? Hold on. I did that duodenum, xanthelasma, hemangioma. How did we jump to the picoma?
Yeah, we missed the hemangioma.
Okay, so this is a hemangioma of, sorry, the location was esophagus. Okay. Oh, very challenging. Because when you have a hemangioma of the esophagus, you want to make sure that you're not missing a vascular tumor, a vascular malignant neoplasm. I'm not the most expert in soft tissue, but I would definitely show it around and make sure that those nuclei are not too plumped to call it anything. But what I'm seeing here, that it's well circumscribed, if you can see, it has almost like a nodular look to it. As far as I remember from my soft tissue is the edges of that lesion should not be infiltrative. And, but definitely it's almost like a cavernous hemangioma. Lots of vessels and nice. UC. Oh, no, malignant, but oh yeah, UC. Let's do the UC. Okay, this is the bread and butter of our non-malignant colon biopsy. So we have two examples of UC. Okay, remember UC. It is there is no skip lesions. It can pretty much affect any part of the colon. However, it's more common in the distal and the rectum and rectosigmoid. It's either pancolitis or proctitis. It doesn't like just come like a small patch in the transverse colon, for instance. Okay, it's usually more of a continuous involvement. And treated versus not treated, the patient will be, you will see a lot of biopsies. So you'll be familiar with the names of your patients if you're following up on patients in the same center for a long time. The most important thing in UC, really, is to make sure there's no dysplasia. Okay, so the doctor will send some biopsies to you. He will tell you, check for activity, because for him the colon looks normal. For instance, he will say check for activity and check for dysplasia. So make sure that those are the two items you are completely responding to his requests on your biopsy. Okay, so let's see, we have chronic colitis. Why? We have crypt branching. See how the crypts are almost branching here. This is a good one. Crypt branching. Crypt glandular disarray. We have almost like a crypt loss. Here you have loss of crypts in this area. So this is more of a chronic colitis picture, okay? And then you have basal lymphoplasmacytosis. Lymphoplasmacytes are just pretty much in the band underneath. This is the chronic part. Now for the active part, there are only two things, cryptitis and cryptapsis. So this is a cryptapsis. Okay. And let's see, simple cryptitis, where you can see a neutrophil inside the epithelium. And I'm pretty sure you've all seen that. Okay, so again, so in your head, your checklist for chronic active colitis is crypt rationing, crypt loss, glandular disarray, cryptitis, crypt abscess, basal lymphoplasmacytosis. Okay, so now you made the diagnosis of chronic colitis. Now you want to see the severity. You want to make sure that this is mild, moderate, or severe. Okay, this is very subjective, and there is not, you know, strict criteria to call it. Here's a nice cryptitis. Okay, not a nice criteria, but I will look at all my pieces like that. And for me, I would say, okay, this is involved. Oh, sorry. Okay, this is involved. Why? Okay, all right. This is involved. All the pieces are involved. Probably this is not as involved with activity. So I will call this moderate. So chronicity, I do not grade. I just grade activity. So I will call this chronic colitis, comma, moderate activity, C comment, okay? And in my comment, I will mention, oh no, next line I will say no dysplasia present, okay? No granulomas or dysplasia present. I'm mentioning no granulomas because I want to reassure the doctor that this is a true UC case, and I don't see a granuloma. And the other thing is no dysplasia. The epithelium looks very light, that I don't even need to go high power. I don't have any darkness on the epithelium that makes me think that I have to go high power, okay? So these are the items, and then
How do you grade your mild, moderate, severe? Can you elaborate on that?
Say that again.
How do you grade your activity mild, moderate, and severe?
Yeah.
Can you?
Yeah, so I will see how many pieces I have, okay? And I know that all these pieces have chronic colitis. However, 2 of them have the activity, then I will call it moderate. If I have only one with activity, I'll call it mild. But if, let's say, I only have one piece, okay? Let's say I only have one piece of the colon, which is very rare. They're usually very good about pulling a lot of colons in these patients to rule out dysplasia. If I have only one piece, then I'll just use my judgment. Do I have a lot of cryptitis and crypt abscess and mucin depletion and blah, blah, blah? So I will just, you know, it's very subjective. Honestly, there's not a single thing that you have to follow. The lifesaver thing in pathology is we have a lot of moderates in our words. So you can always call it moderate. All right, let me just drink a sip of my coffee. Okay, so again, look for dysplasia. That's very important. Next is HPV-associated adenocarcinoma with associated glandular dysplasia and AIN1. Okay.
AIN3.
I'm sorry, AIN3. Okay. So the nice thing about it that we can cover multiple things, and then how is it in time for you guys?
I can study for the whole day. It's about you when you have time.
I love you, Akansha. You're just so enthusiastic. I will take a break for 5 minutes after that, and then we can resume for another half an hour. Sounds good?
Yeah, sounds like a plan.
Okay. So we'll take a break. Okay. Now and everything. So let's see. We have PAX8. We have P16, we have HNE, we have CK7, we have CK20, we have CDX2. Beautiful. Let's go to our HNE. Okay. So this is ano-junctional mucosa, right? Ano-junction mucosa. Ooh. Those nuclei are ugly. right? In the glandular epithelium. I have pseudostratification in everything. But again, the one thing you have to keep an eye is the surface. Here, see that? Okay, dysplasia. Why am I calling this dysplasia? Because my nuclei are switching from dot in the bottom to more long, reaching the surface. And after it became a long pencil shape, it's becoming rounded. I wish somebody explained that to me when I was younger. Really, really, it was so difficult for us to, I don't know about you girls, but it was such a difficult thing to my eye when I was in training. I mean, look at the transition between the normal dots to the abnormal epithelium that is long here, and then it became rounded. So if round at the base and then long and then round at the top. This is how you should think about it. This is, see, I mean, this one, if you have it, you'll call this a tubular adenoma, right? Yeah, so it's from tubular adenoma all the way to high-grade dysplasia. I think this is, okay. So this is definitely
this. You would call it as high grade.
Why would I call it this? I don't like this here. The nuclei here, it's very ugly. But of course, I have to see more and more and more. This one, if it's not too convincing to me, I will call this at least low grade.
Low grade, yeah.
Yeah, at least I would use the word at least. That means I'm just telling the clinician that there is something worse. And of course there is.
Yeah.
See that? Vroom, 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 vroom. This is invasive adenocarcinoma. And I have a surface dysplasia, so I know that this is coming from him. I'll definitely do a CDX2. Where's my CDX2? Here's my CDX2. My CDX2 is negative.
It's not that great, I mean.
My CDX2 is negative. I wonder if the anojunctional one is different than the one that is in the colon. I have to read about it really quick. Okay, I'll read about it while you guys are taking a break. But CK20.
Don't read about it while break. While break, make use of the break, and you can read about it. Yes, really. I mean, you need the break too.
It's okay. It got me very, very curious. Okay, and this is CK7. I wonder if this is a squamous component. Okay, not a glandular component. Ah, that makes sense. Huh?
It has some squamous metaplasia.
Yeah, that's why, because let's see, I don't know, I'm just very curious. Okay, so let's now see the squamous epithelium over here, okay? So they said there's AIN3, right? Let's see. Definition of AIN3 is to have mitosis in the upper third, correct? So let's look at, definitely, this is definitely an ugly epithelium. This is not, yeah, it's not something that I would run. It's probably gonna stay on my desk for like 2 days, screening it. But I need a better squamous component. I really need a better squamous component, but they don't have it here. So the only one is the one that we've been looking at the very beginning, this one. So it is very immature look, right? It almost looks like the whole thing is basaloid. Now let's look for mitosis. This is one here, I think.
Yeah.
And you have to get one at the surface. This is another one here. maybe you have something here. You definitely have it. Okay, so here is AIN. What I do usually for my AINs, it's either condyloma accumulata, which is AIN1, or I would do AIN2-3 on my biopsies, because I'm telling the clinician that I found my mitosis in the middle. Doesn't mean that I didn't find it in the third, but it's middle and third. And the reason I joined them together because they're managed the same way. Okay, and you don't have to commit yourself right away to all of that. You can just call it AIN.
Does P16 help you?
So, say that again.
Do you do P16 in these cases?
I do P16, and it helps me. And P16, look, they're all P16 positive, and look what happens here. Our suspicion about this being a squamous, that's why it wasn't a CDX2 positive, because these pockets were all squamous epithelium. P16, and it's almost like a junctional, like, look, it almost has a glandular. What did he describe?
Yeah, that's what I'm thinking. Like, it looks like arising from the glandular area and has more squamoid type of everything.
That's what it is. It is HPV associated adenocarcinoma with associated glandular dysplasia and AIN3. Honestly, this should be a Montgomery case. I mean, it is so complicated.
I know, right?
I'm not joking. It's
no, really.
So,
I mean, this looks
so
like it is arising from that dysplastic epithelium over there, and then it has more squamoid type of IHC and appearance. So that's weird.
Yeah, but it's the nice thing about it, look at the difference between the HPV associated glandular and the normal. See how when the HPV, it's probably started in the squamous, and then the HPV crawled up into the glands, and then now it affected the glands. The glands were so naive, they became dysplastic, and then they became carcinoma, adenocarcinoma. They invaded the lamina propria, they went down, and then they started throwing tumor droplets all the way into the lamina propria and the submucosa. But this is so impressive. Honestly, I have never seen HPV-related adeno. Okay, we've always been relating the HPV to glandular, but this is quite impressive. All right. And then you do your PAX8. There it is, so positive. What a nice case. Okay, all right, we're gonna take a break right now.
Yeah.
And I will resume at 8:15. How about that?
So that would be 11:15 here.
Yes.
Okay, sounds like a plan.
Okay.
Okay.
All righty.
See you then.
See you then. All right, are you guys back? Hello?
Yes, we are back.
Okay, perfect, perfect, okay. All right, moving on. Where are we? We have looked at UC, chronic adeno, HPV associated, okay. Mild acute periappendicitis. Hello, where is my appendicitis?
I know.
Okay.
What am I dealing with here?
I don't think this is an appendix to start with, because it doesn't look like an appendix.
Yeah.
Almost reminds me of
It's kind of a soft tissue tumor or some kind.
it's a gist.
Yeah, yeah.
This is a nice looking gist. Let's see, it's probably mislabeled. Let me look at the epithelium. No, I don't have an epithelium. And look at this necrosis. So in the criteria of describing gist, you mentioned the size, location, presence or absence of mitosis, and the Ki-67 index. So these are all items that the clinician, and this is a resection specimen. So this was a very important thing to, I don't think this is labeled correct, honestly. This is, yeah. Let's see the CD117. Yeah, I mean, it's a giveaway. The CD117 is here. So just remember to have all your criteria before you sign out this case. Monomorphic epithelioid intestinal T-cell lymphoma.
Yeah.
I
It's just
will-
if you go into one of the GI cases,
Uh-huh.
don't go in the lymph node, go in the GI.
Oh, okay, that's fine. The GI, so
Small bowel. Do you see the small bowel there? Small bowel. HNE.
yeah.
Go to the HNE of small bowel. Down, 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 down.
Alrighty, there it is.
Yeah.
Okay.
So your epithelium, if you at all see an epithelium here,
No, I
there
don't see
would be,
anything.
yeah, you should ideally see the epithelium, and this area is from just the tumor. So
Okay, let's see if there's another H&E.
yeah.
No.
Another.
Again, let's look at the last one. Hopefully we're gonna get an H&E. Okay, they're all tumor-based biopsies.
Is there a
So
little bit of epithelium on the top over there? On the go, no, over there. No, not there. Down, 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 not there. Down.
oh,
What happened?
okay, so what are we supposed to see in the epithelium?
So it will be just that it will be small monomorphic T cells that will be there, and it's mainly like so that's why the name monomorphic epitheliotropic T cell lymphoma. So basically it will be all monomorphic cells. So even over here you see that they're all monomorphous small cells, and the nice picture of the epitheliotropism, maybe a little bit over here, it's not that great, but a nice epitheliotropism, if they would have demonstrated that, that would have been very nice. So just like you see your like celiac disease and microscopic colitis and stuff like that, you'll see a lot of lymphocytes in there. And
like
yeah.
here, this is a small fragments of epithelium, and you'll see them like here, just like celiac. Okay.
Yeah, but then you will see a lot of them, and then
it's
and
like
then
lymphocytic colitis picture.
Yes, exactly. And then you have all of these big. Usually the cases that I have seen, they are like this. They are big, and then there's a lot of sloughing of the epithelium too. But then whatever you see are the monomorphic cells. And these cells, they are CD8 positive. They are CD56 positive. So I mean 3, of course, but these are T cells, so 3, 2, but they have given a CD8 stain over there as well.
This is our CD8.
So you see nice CD8 positivity in them. They are CD4 negative.
Oh, that's the trick. Okay.
Yeah, and CD8 positive.
So this is a CD4. Let's look at it. And
so you see that majority of the cells in cells
are negative.
And that's it. Like differentiating this from ETL is important. ETL is epitheliotropic T cell lymphoma. So ETL and METL are 2 different things. METL is monomorphic epitheliotropic T cell lymphoma. So ETL will be CD8 negative and CD56 negative. So those will be your 2 stains that are going to help you with the ETL and METL as well. With the METL, you'll have that monomorphic appearance as well. So that will also help you. But CD8 and CD56 are your two stains that are going to help between etal and metal.
Got it. Got it. Got it. Okay. Nice. Thank you for the overview. I will still send it out. It's nice.
Just send it to me.
It's, okay. Next is malignant gastrointestinal neuroectodermal tumor. Oh my God. Jeanette. Okay, this is very rare. This is a very, very rare disease. That is so cool. I can't believe that they have a case of it here. Okay. It's usually a disease of younger patients. What's the location? Sorry, hold on. It's the jejunum. Yeah, small bowel is more common. Okay, so on low power, this is a biopsy of what appears to be small bowel with a little bit attenuation of the epithelium. It's all kind of narrowed down. And there's expansion. And then definitely there is some erosion here. And a tumor here. Okay, let's look at that tumor. So what comes to your mind here when you look at it on low power? First thing that comes to my mind is neuroendocrine tumor here. Kind of monotonous, it's in sheets. But what is something that doesn't go with neuroendocrine tumor is the prominent nucleoli.
Yeah, the prominent nucleoli and the
yes. So now you're getting lots of mixed messages. You will cook your stains, think overnight, and come the next day with fresh eyes, because this is a very challenging case. Oh, I can't believe they have a case of it. Okay, so what you will do is you will do a DOG1 or a CD117. You will do your S100 to rule out melanoma. You will do synaptophysin chromogranin. Also, you'll do a keratin, okay? And then this is your first panel. Let's say keratin negative, S100 positive, chromogranin positive. Okay? Now what you're gonna do? Am I dealing with a neuroendocrine tumor? Am I dealing with a melanoma? There is an entity, gastrointestinal neuroectodermal tumor. It is melanoma marker positive, which is an S100, and it is synaptophysin positive. So you'll go ahead and do a SOX1. SOX1 is more specific for that entity. And I personally will do the rest of the melanoma markers, melanA, HMB45, and these have to be negative. So this tumor is very challenging to diagnose, but the giveaway is the age. Patients are very young, less than 20 years old. Okay, it doesn't happen pretty much in older ones. Let's see, what do they have here?
They have SOX10 and S100.
Oh, nice. These both are going to be positive. Okay. That's my SOX1. That's, I'm sorry, my S100. And
SOX10.
oh,
Above, up. Yeah.
oh, there you go. Okay. Again, that's your SOX10, okay? So these all are looking like melanoma. However, you do HMB45, you do melanA, these are negative, but your synapto will be positive, okay? Nice. They don't have a synapto here. That's oh, here. No, they don't.
No, that's not,
okay. Mixed. Okay, EBV positive mucocutaneous ulcer.
That's also one of the, the skin / hematolymphoid diagnosis.
This one?
Yeah, EBV positive mucocutaneous ulcer.
Okay, so I'll do the H&E first and see how it looks. Where's my, so this is a resection specimen. You guys are challenging me with resections. I don't do resections.
It's just that there will be all that ulcer in there, and there will be, this is again a T cell kind of phenomena, and you'll see all sort of mixed cells in there as well. Like in the periphery, I think there are more of CD8 positive T cells, and then it's EBV positive. It's gonna be EBV positive and
Eber. Okay.
EBV positive and everything.
So, so what you do in this case is you do CD30?
Yeah, there will be immunoblasts that will be admixed in there. So CD30 positive immunoblasts can be seen in these cases. So you can see those big cells.
Okay.
And they will be admixed in between those T cells, and then you'll see the Eberish.
I'll show, but for the majority, they are CD20.
Yeah, yeah.
Okay, and then we'll do the Eber-ish.
I think I misspoke. It might be a B cell. It's very uncommon. I have seen a case from MSK, just one case.
Oh,
and, yeah.
That's a nice Eber.
Yeah, it's very Eber positive. That's what it is. Like it's very EBV driven.
Okay. All right. Next is mixed neuroendocrine, non-neuroendocrine neoplasm. I don't know if I have made that diagnosis before, but let's see.
It's just that there will be mixed both components, right?
Yeah. Okay. So telling you that there is a glandular and neuroendocrine differentiation. Yeah, so it's a mixed tumor. Okay. My colleague had a case last week, gastric cancer that looks like adenocarcinoma. It was 100% positive for synaptophysin. 100%. Not a single cell that was not positive, and it looks like adeno. So is it neuroendocrine tumor, neuroendocrine carcinoma? Is it an adeno with neuroendocrine differentiation? Lots of people had lots of opinions about it. Multiple mentors of both me and my colleagues looked at it, and they were like, okay, this is a mixed tumor. We ended up sending it to Montgomery. She responded a couple of days ago mentioning that this is adenocarcinoma. And she comments that in the comment that it's synaptophysin positive. So we call her back and we're like, why don't you call it with neuroendocrine differentiation? She's like, because based on morphology, this is adenocarcinoma. Patient has to be treated as adenocarcinoma. I don't want to confuse the oncologist and tell him that there's neuroendocrine features. Because based on morphology, we're going to follow morphology and go back to our basics. So that was a very interesting case that morphology rules, even if the immunostain doesn't follow the exact, because it looks like adeno. I mean, imagine it was pretty much like this, but this is synaptophysin positive, you know? It's just so, but of course they're calling this mixed because you have those areas here are going to be neuroendocrine, like synapto. Can you guys hear the kids upstairs?
Very, very friendly. I mean,
oh my gosh!
Since you said it,
I noticed younger kid, which is my husband, is playing with them. I think I should.
Don't worry about it. You're fine. Your voice is very clear and nice.
Yeah, no, it's just they're all normal. So just reassuring you. Okay. All right. So next I have. I'm going to move on to the hyperplastic metaplastic polyp of the colon. I don't know why they call it metaplastic. Let's see. Oh, too orange. This is just the usual hyperplastic polyp. Okay, but if this was in the ascending colon, you will call this SSA. Okay, location matters for me a lot, but this is a rectum. I'll let it go as HP. All right. Duodenum, ectopic pancreas. No, where am I? Here, GI, stromal tumor. Yeah, means just. How come? Okay, makes sense, right? Almost looks like a core biopsy or FNB of a stromal tumor of the. Correct. And you have a spindle cell lesion. You'll just do your immunostains and tell them that you are looking at a core, and this may not be representative of the entire lesion because you don't have necrosis, you don't have a lot, it's just going to be a core biopsy diagnosis. Okay, moving on. I wish I can finish page 7 at least today. This way we can, Crohn's disease. We've done quick Crohn's before, but what you want to look for granulomas, right? On low power, just by looking at low power, you find expansion here, and you go there and you find a beautiful granuloma. It's deep seated. It's in the exact place where you want it to be. You look at the rest of the epithelium. I don't call it no chronic colitis because the granuloma defines chronicity, okay? Almost here you have like an erosion, ischemic changes, right? See how the lamina propria is hyalinized?
Something. Tell me one thing. So in a case of UC or even Crohn's, if you have the chronic colitis changes, like all those cryptarchitectural distortion and branching and all of that, but you don't see any activity and you don't see any granulomas, you don't see anything else, just that some chronic changes. Would you mention it as chronic colitis versus you would mention, not mention the chronic colitis?
Oh, no, of course. Any chronicity findings, you have to mention it.
Yeah.
So, if the patient has history of IBD and I see chronicity, I say quiescent colitis, okay? Or you can say chronic colitis, no activity, consistent with patient's history of IBD, all right? If I have chronic colitis features, no activity, no history, okay? I will say, I'll be descriptive, crypt architectural distortion or basal lymphoplasmacytosis or glandular disarray or whatever the chronicity feature is, I would say see comment, okay? And this could be in chronic resolving infectious enteritis adjacent to a diverticulum with chronic insult. You know how a diverticulum kind of pops and inflames and gets better and inflames and it gets better. So even adjacent to a diverticular disease, you'll have some chronicity, drug-induced injury, or resolving infectious IBD that is not resolving, like silent IBD that has not been diagnosed yet. Okay, so you have to be descriptive. You can't. Just to point out something which is a very common thing. I don't want you to look at this gland here and call it low-grade dysplasia. Okay, it is deep in the next to a granuloma. The surface is eroded. Definitely, your epithelium will become angry and become more pencil shaped. But this is not the area where you need to look for dysplasia, okay? You need to look for dysplasia, you need to look for it in an epithelium that is intact, like here, okay? And don't worry about the deep crypts here. These are all just normal. Okay, so this is your nice Crohn's. Also in Crohn's, you have to see that you get those skip lesions, some areas that are normal, some areas that are chronically inflamed. Okay. Angiomyolipoma. No, okay. Colon Schwann cell hamartoma. Okay. By far the most the most favorite subtle, non-significant, but I feel so proud and happy when I make it. It is really, 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 really not significant, but to be able to pick it up, I really find very much joy in it. Okay, this one. It's just some pinkish material underneath the lamina propria. And my trick about this, because really it's very difficult if it's a small biopsy. I mean, you will basically have just this area here. And my trick about it is I go on low power. I look, I know this is all normal. And then I see here, I feel like it's busier, okay? And then that tricks me to look a little bit higher. I always screen my glands. My glands should not show hyperplastic features. They have to be small and round and no hyperplasia, okay? If you have hyperplastic changes, you're dealing with a perineurioma. If you don't have hyperplastic changes, you're dealing with mucosal Schwann cell hamartoma. And from the name implies, mucosal. It has to be in the very, 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 very surface mucosa. And now, of course, you do an S100, and there it is. Mom, I'm in a meeting, and there it is. It's so beautiful. I'm very obsessed with this diagnosis. I do it very frequently. I love it. Although it's really not significant. I wish I was.
Do you get a call after the diagnosis?
No, because I have a comment. Telling me that this is not significant. Okay. Increased intraepithelial lymphocytes in normal villus. Of course, this is a duodenum. And I would say at least twice or 3 times a week I make this diagnosis, okay? On low power, I have very, very nice villi of the duodenum. On high power, you have to look at it at the very tip of a villus that is completely normal, which means I have 1/3 underneath and 2/3 up, okay? This is the right villus to look at. For me, 1 is enough to make this diagnosis, okay? And what am I looking at? I'm looking at 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 lymphocytes in that tip, and this is too much. For reassurance, I look somewhere else, and here's another one. 1, 2, 3, 4, 5, 6. Okay. So I have a comment for these. Of course, look for Giardia, everybody. Don't miss it. I have a comment for these. I don't see any Giardia. I have a comment for these. I would say duodenal type mucosa. Of course, this is Brunner's glands. So it's either small bowel mucosa or duodenal. I call it based on my Brunner's glands. I say duodenal type mucosa with mild increased intraepithelial lymphocytes. Period. Next line. Normal villi. Period. Next line. And then no dysplasia or surface parasites. And then in my comments say this is seen. This may be seen in H. pylori infections, as well as emerging celiac disease, Marsh classification type 1, and correlation with serology and serum markers is recommended. Also, I would say my H. pylori stain is negative, especially if it's in the stomach, it was negative. Okay, so you have a nice comment for this. It's not uncommon, by the way. It's very, very not uncommon. Ectopic pancreas in the duodenum. Okay, I have all my 3 boys right in front of me, staring at me, but we're still gonna persist with that. Okay, ectopic pancreas. This is our ectopic pancreas. It will make you think a lot about neoplastic process. However, it is a very, very benign pancreatic heterotropia, which is not uncommon, absolutely not uncommon. Okay, good example. Now my 4th child came in. All right.
If you want to stop, we can stop.
I'm gonna call it a day for now.
Yeah,
I'm sorry, ladies. So
no, you did a great job today. I loved today's session.
I'm glad you enjoyed it. Well, then we will chat. Can
you just do this last case, mucosal ganglioneuroma, go down Cowden syndrome.
Mucosal ganglioneuroma, Cowden syndrome, this one?
Yes.
Okay.
So that we are finished with 8 and 7 then.
Okay. First of all, don't be fooled. This is, okay, what is a mucosa? Okay, what is a mucosal ganglioneuroma? This is, if you look at your nervous system, no, not nervous system, the neuronal tumor, schwannoma is one end, ganglioneuroma is the other end. So it's the mucosal Schwann cell hamartoma, like the one we discussed earlier, but with ganglion cells. Okay, look at them. 1, 2, 3 ganglion cells. See that? This is also, I have made this diagnosis probably 4 or 5 times in my career, not too much. So in the past 4 years, it was just like 4 cases. But when you're looking at your Schwann cell hamartomas, look for ganglion cells. Very simple, and it's just another non-significant one that you will have to keep an eye on your ganglion cells. Okay. Alrighty, these are, so it's literally a mucosal Schwann cell with ganglion cells.
Got it. Okay. Thank you very much.
You are very welcome, Akanksha, and I will talk to you later to decide to finish. I think we still have page 4, 5, and 6, correct?
No, we finished 4, I think.
Oh, we did?
I thought.
Okay. No,
we have 5.
I think 4, we finished 3. 4 we haven't. We have 4, 5, and 6 to go.
Okay.
All right.
All right. Okay.
Okay. Have a good one. Bye-bye. Bye-bye. Bye. Thank you very
Thank
much.
you.
You're welcome.